All right, good afternoon, and thank you for joining the Information Technology and Innovation Foundation for today's event on preserving a virtuous cycle, the economics of biopharmaceutical innovation. I'm Stephen Ezel, the Vice President for Global Innovation Policy at ITIF, and I'll be your host and moderator today. The report we're releasing today reflects the presentations from the symposium ITIF held last May, in which we invited 5 leading health economic scholars, several of whom we'll hear from today, to present our recent research from various aspects of the field. Harvard's David Cutler presented research examining the leading factors which have contributed to the 3.3-year increase in US life expectancy from 1990 to 2015. Andrew Brownlee of the Berkeley Research Group shared research examining the distribution of revenues on drug expenditures across the pharmaceutical supply chain in the United States. The University of Southern California's Niraj Sood presented research examining both that question, as well as looking at the economic profitability of key actors across the pharmaceutical supply chain. Margaret Kyle, an economics professor at Paris Tech Minas, presented research on the optimal types of push, pull, and indirect policies that governments can implement to maximally stimulate biopharmaceutical innovation. And Christina Liebecker of Colorado College presented research she co-authored with Erica Leitzen, which examined the true effective length of patent life for drugs in the United States and the role this plays in stimulating breakthrough biomedical innovation. Now that research is summarized in our paper, what I want to show today is that we're going to have presentations from David Cutler and Niraj Sood, who were at the symposium, followed by Sue Peshin of the American Alliance for Aging, who will share a patient perspective on the broader implications of the economics of biopharmaceutical innovation for the patient population. I will then come back up and share some perspectives from ITIF's point of view on these topics, and we will go to Q&A. I'll introduce our panelists now, but let me say that via the Slido application on our website, you can submit questions there, which we will take in the final 20 minutes. Okay, so first we're going to hear from Mr. David Cutler. David is the Otto Eckstein Professor of Applied Economics in the Department of Economics at Harvard University, and previously a Harvard College professor from 2014 to 2019. He holds secondary appointments at the Kennedy School of Government and the School of Public Health, and is a research associate at the National Bureau of Economic Research. David will share findings from the report he co-authored with Jason Buxbaum, Michael Chernew, and A. Mark Fendrick, titled Contributions of Public Health, Pharmaceuticals, and Other Medical Care to U.S. Life Expectancy Changes from 1990 to 2015. Next, we're delighted to be joined by Mr. Niraj Sood, Professor Dr. Niraj Sood. He is a professor and vice dean for research at the Sol Price School for Public Policy at the University of Southern California, where he also directs research at the Leonard D. Schaefer Center for Health Policy and Economics. Niraj's research focuses on economic epidemiology, infectious diseases, pharmaceutical markets, health insurance, Medicare, global health, and economics of innovation. He's likewise an NBER research associate and a board member of the American Society of Health Economists. Niraj will present findings from several of his recent papers co-authored with colleagues, including the flow of money through the pharmaceutical distribution system and do companies in the pharmaceutical supply chain earn excess returns. Last but not least, we are delighted to be joined by Mrs. Sue Peshin. She is president and CEO of the American Alliance, or the Alliance for Aging Research. No American at the start, the Alliance for Aging Research. But they are the leading nonprofit organization dedicated to accelerating the pace of scientific discoveries and their application to vastly improve the universal human experience of health and aging. Sue leads the organization's efforts to increase federal investments in aging research, raise awareness of geriatric cardiovascular disease, advocate for patient affordability and equity-based value frameworks while improving access to Medicare treatments. Sue previously served in senior roles at the Alzheimer's Foundation of America, Consumer Federation of America, and the Violence Policy Center, and she serves on numerous boards, including that of the National Health Council and Voices of Alzheimer's. So let me turn it over now to David. And David, you're welcome to come up here if you like, or you can do it from there. Here's a slide clicker. And as we get going, let me just say that the views and perspectives and opinions of all our speakers are their own. When I present ITIF's views on the implications of this research, it will be from our perspective. David, the floor is yours.
Thank you very much for inviting me. This event makes me think that maybe COVID is receding even more because, in fact, if I recall correctly, we had to cancel the in-person version because of COVID. And so, like, I sort of see this as a marker of like how life is improving. So I'm very glad to be here for all sorts of different reasons. I want to talk to you a little bit about understanding the contributions to health improvements. And, one of the great innovations in the world in the past century has been the improvement in life expectancy. So we went from a world where people didn't live very long to one where in most developed countries, people can live a long time. And so the question is why that occurs and what does that then imply about policy? So my colleagues and I undertook some analysis into this. This is not on the sort of very, very broad scale of a couple of centuries, although there are a number of fascinating papers on that, but over the roughly 25-year period or so from 1990 to 2015, and you'll see a little bit why that period of time is something that we look at. If you think about that period of time, you say, well, obviously medical care is such a big deal and it must be so important. On the other hand, there are all sorts of other things that are going on over this time period as well, ranging from things like improvements in, let's say, lower pollution in a number of different areas, to things like improvements in economic circumstances that will improve longevity, to things like behavioral changes, reduce smoking, and so on. So it's sort of disentangling all of that is a very difficult issue. And so what we try to do is to do some of that disentangling. Of course, there are also things that may have a negative impact on health. The biggest one in the medical care industry is opioids, which led to a very large increase in death. So we want to sort of try and put this all together. And so let me tell you a little bit about that. So first, the basic fact, which Steve mentioned, which is that people are living a little bit more than 3 years longer in 2015 relative to 1990. The 2015 value, I should say, is not because there's sort of any magic date there, but as we were doing the analysis, we needed like some really, really detailed information on things. And so that was at the time as recent as one could get. There's obviously now an issue since COVID, and of course the vaccine since COVID and the treatment since COVID have had enormous impact. So I suspect, if anything, these would show fairly similar findings if one extended it, but obviously I haven't done that. So how do we go about doing it? What we really do is in 2 steps. And so the first thing that we do is we say, how much of that life expectancy improvement can we parcel out to different causes? So every cause of death, every death that's recorded has a primary cause. There are often multiple causes, but we took the primary cause here. And we sort of divided them out into, in this case, as you can see, 114 different causes of death. We subsequently then rolled them up into things that were fairly similar, because 114 gets you some things that are fairly small. So 114 causes rolled up into things. So for example, ischemic heart disease is one category, lung cancer would be another category, and opioid deaths would be a third category, and so on. And then for each of those causes that we had, or the rolled up causes, we then tried to attribute how much of the improvement in health was a result of, or improvement in survival was a result of 3 different factors. One is public health. So things like improved pollution environments, or reductions in, we're going to put reductions in smoking in there. Second would be pharmaceuticals. Third would be other medical care. So we really want to differentiate between the pharmaceutical and the other medical care part. And then, of course, there's a residual other unknown part, and that's just reflecting our lack of knowledge about everything that's going on. How do we do that? The way that we do that differs a fair amount across different conditions. So sometimes there are statistical models. So people have estimated various statistical models for things. So they're very good models for heart disease and for cancers and so on. Sometimes people don't have such great models. So we use physician surveys. So physicians have been surveyed in a number of cases about how do they think about what's been important. Sometimes there's a literature review where the literature has sort of try to look at various things. So even if it's not a formal model, people will say things like, oh, well, in the clinical trials, these particular therapies had the following impact, and we would know what had happened to use of those therapies over time, so we could therefore estimate what had happened to health improvement as a result of that. So a variety of different methodologies here, and in some sense, the heart of this is really in there in terms of whether you believe it, and so we try and spell that all out in the paper so that you can get a sense of that. So let me first show you the first step of that, which is the first part of, which is what are the causes whose reduction in death rates has led to increased survival. And you can see the single biggest one of these is circulatory disease conditions. So if you just look over this time period, like if you say, why is it that Americans are living longer from say 1990 on, like just basically the thing that comes out, that just dominatingly comes out, is heart disease and stroke, particularly the heart disease part of it. So that by itself is over half of the net change comes from that. Roughly 2/3 comes from cerebrovascular and heart disease together. So you see those. You then see certain cancers, not across the board in cancers, but a number of cancers, lung, breast, and colon cancer. And then you see some things that look a little bit more like public health, so reduced automobile deaths, which is interesting because vehicle miles are going up, but vehicle deaths are going down. And so the safety per mile has been increasing quite a lot. And then you see a variety of other things. Homicide went down a bit over this time period, infant mortality, and so on. In the other dimension, so those are all the things that went up, of course, for which life expectancy went up. There's some things leading to a reduction in life expectancy, and those are really important to note as well. The two biggest ones, which we highlight here, maybe three of them, poisonings and drug overdoses, very, very big issue associated with higher mortality, less long survival, and then Alzheimer's and other dementias. And so that, and I know Sue will have much more to say about that, but that's sort of showing you, basically as people are no longer dying nearly as much of heart disease and some cancers, what's coming to the fore are these sort of chronic, very debilitating conditions of old age that lead to death in many circumstances, and that's what you see there. These are all age adjusted, so I should say it's not just that they're more older people, but these are all adjusted for the age of the population. Okay, so that's the sort of demographic part of it, or the epidemiological part. We then get into the economics part of it, which is what can explain things. So let me take the cardiovascular disease mortality one, just because it's so big in the total here. So there's models that have been developed that go through and say, okay, what is the impact of different types of things on cardiovascular disease mortality? There have been quite a number of these models over time. We actually extended one of the recent models that's been published both in the US and in other countries, and is sort of seen as the leading model on it, the impact model. And then we said, okay, what factors does that model say would lead to improved health in cardiovascular disease? And you can see here the two dominant parts. The first one in red is pharmaceuticals. So what that is antihypertensive drugs, statin drugs, cholesterol-lowering drugs, and diabetes glucose-reducing medications. All of those are extremely important. Like if you look at every single one of them, they're all extremely important in survival. And you can see that it's actually, and one of the interesting things about this is that it's not just survival, but it's actually the share of people having an acute cardiovascular event is actually falling over time. So it's not just on the survival end, but it's actually, this is, I think, the first example that I've ever seen of where a medical innovation, a less relatively inexpensive medical innovation, has actually saved money overall. Most of the times we think they might save money, but they tend not to do that. And this is, I think, the first case where they do. So that's the first part, is the big red bar. The second part is the blue bar, and the blue part of the pie here is the public health part, and what should be immediately jumping into your mind here is smoking. So big reduction in smoking leads to a big reduction in heart disease. Somewhat more interestingly, there's sort of all the kind of very intensive stuff that you think about, putting in a stent and doing bypass surgery and all of that sort of stuff is important, but quantitatively it's a much smaller impact than many of the other things. So the sort of rescue part of medical care has been less effective than the preventive part of medical care, and that probably has some lessons for other parts of the health system as well. Okay, so if you then do that and you say, okay, so let me do that across all the different conditions, like, I sort of showed you the conditions, let me do that for each of the conditions and see what you get. Here's what you get. The biggest component by percentage is the public health improvements. So those are the reduction in smoking. That also shows up in a number of the cancers, and so on. So that's about 44% of it. Then pharmaceuticals is 35%. Again, the biggest positive contribution to that is the cardiovascular ones. On the negative end, the biggest negative end is the poisonings and drug overdoses, which is just a huge issue. And that, of course, was getting bigger after 2015 as well. So this is the net of those. For whatever, it's hard to know, in each of those categories, whether you put it into a pharmaceutical bucket or whether you want to trace it back further to something like a social change or social anxiety bucket. We're going to keep that in the kind of primary pharmaceutical bucket here. And then you have other medical care, which is 13%. And then there's a residual. Whenever you do these things, you hope the residual is small. You don't know going in whether it's going to be big or small. In this case, it turns out to be relatively small. So we can explain about 85% of the improvement in health this way. Just a quick summary here. The primary drivers were public health and pharmaceutical intervention. There was a lot of heterogeneity in that many of the advances were high tech, but many of the most important advances were actually not super expensive. By not super expensive, I mean the sort of daily medication that you take that's $2 or $3 a day when it's branded, and even cheaper when it's generic. And some of what happened over this time period is these drugs went generic, and many more people could afford them. Progress from evidence-based diffusion of technologies to new populations is a very big deal. There can be harm from over-diffusion, which one wants to think about, particularly in opioids, where you think about harm from over-diffusion. But then in other cases, there's still examples of populations that are not getting enough. So we sort of have the coincidence situation of some people getting too much and other people not getting enough. And then just, of course, the question that I sort of start off with, which is, these results can differ over different periods of time. If you went back far enough, you would have thought that medical care was just totally harmful. That is not sufficiently valuable if you went back. And then, of course, as you go forward more in time, the medical contribution is likely growing. So thinking about this at different points in time, or indeed going forward in terms of COVID, how one thinks about that is important. So let me stop here just with that summary of what we had done. And thank you for inviting me. And it's a pleasure to get to see everyone.
Thank you very much, David. That was great. Niraj, let me pull up your slides.
So thank you all for coming here and braving the rain. And thank you to those online also.
There you go.
Okay, so I'm going to kind of take a step back. David talked about pharmaceutical innovation being a major driver of improvements in life expectancy. I'm going to focus on how these drugs actually get to the patients from the manufacturers, and what do the economics of the market look like. So if you look at the supply chain, it looks like many other drugs. So there's a manufacturer. The manufacturer gives the drugs to a wholesaler or a distributor, who in turn gives the drugs to a retailer like a pharmacy, and then a patient goes to a pharmacy and gets the drugs. So this looks like a pretty normal kind of supply chain. But we also know that we have insurance. And when we have insurance, there are other people who enter the supply chain. So one of them is the health plan. One of them is your employer, who sponsors your health plan or sponsors your insurance coverage. And another is an entity called a PBM, or a pharmacy benefit manager, who helps the insurer manage the pharmacy benefit. And I've kind of shown what each of these entities do. And so now if you start looking at who's paying whom, those are the green arrows here, and you can see it looks like a mess. The initial picture was like this nice straight line, but now it's a mess because everyone's paying someone, and a lot of these transactions are kind of hidden. So we don't know who's paying whom how much. So what we did was we tried to make sense of this mess, and by looking at financial statements of these firms. So a lot of these firms are publicly traded, and there's a requirement to report their financial statements to the Securities and Exchange Commission. So we asked a pretty simple question, which is, and the other thing is, who's paying for all these green arrows in the end? It's all of you in the audience, right? It's the customer. It's the eventual customer who's paying for it all in the end, either as reduced wages or directly as out-of-pocket costs. But we are the ones who are paying for drugs, not the PBM, not the health plan, not the pharmacy. Ultimately, we are paying all these entities. So basically what we asked was, if I, as a customer, am spending $100 on a drug, how is that $100 distributed across all these entities in the supply chain? And the answer is that of every $100, about $59 reaches the manufacturer, who did the R&D to come up with the drug, manufactured the drug. But the remaining $41 is going to someone in the supply chain. It could be going to the PBM, going to the retailer, going to the health plan, and so on. So in some sense, the first lesson here is we got to pay attention to these $41 and figure out whether this is too much or too little. So that's what we did in the second paper, which is, we said what we're going to do is we're going to again look at the financial statements of these firms. And each firm kind of does two things. One is they get money from the market, either by issuing a bond or issuing equity. So you can kind of figure out what their cost of capital is, which is like, what is the interest rate they need to pay to people to get money from them? And now they invest that money in their firm and they make profits out of that. So now you can estimate what is the return they get on that investment, right? So if I borrow money at 2% and I invest it and I get 5%, my excess return is 5 minus 2, which is 3%. So we estimated this excess return for every firm in the S&P 500, which is representative of large firms in the US, as well as every firm in the pharmaceutical supply chain that was publicly traded. And what these data show is that compared to the S&P 500, if you look at the unadjusted returns, which is just kind of taking these returns at face value, what you find is that the biotech sector makes much more than the average firm in the S&P 500. So the average firm in the S&P 500 makes 4.2% excess return. The biotech sector makes 13.1%. The pharmaceutical sector, which is the small molecules, they make slightly more at 4.7%. And the middlemen also make much more than the average firm. So they're making like the insurers, PBMs, retailers are making about 5.9%, and the wholesalers are making about 9.3%. But if you adjust this return, so one of the things is that a lot of these firms invest in R&D. And somehow accountants think about R&D as an expense, but economists think about R&D as an investment. So since I'm an economist, I was like, I don't trust the accountants. I'm going to change R&D to an investment. And that's what's shown on the red bars. And you can see that since the biotech sector invests a lot in R&D, their excess returns reduce when you treat R&D as an investment. And pharmaceuticals now, their excess returns are much below the S&P 500. And now you can see what's happening to these returns over time. So if you look at biotech, they had couple of years of really high excess returns. And guess what that was? That was the new cures for Hep C. So there was a major breakthrough. They made a lot of money, and then they kind of declined. But if you look at the middlemen, you can kind of see a clear pattern that their excess returns are rising over time. So you can see that, and their excess returns are higher than the S&P 500. So then we kind of did this third paper, which I'm going to talk about, is insulin has been in the news, and everyone's talking about rising insulin pricing, and now I guess more recently falling insulin pricing. And so we wanted to understand what the insulin market kind of teaches us about the economics of the supply chain. And we cobbled together data from a variety of different sources. I'm going to skip that. And now this is that same flow of funds, who pays whom what. Each flow is given by a number. For each flow, we went to public sources like regulatory filings, Medicare data, et cetera, to estimate that number. So now let's look at what we see in the news. What we see in the news is the number one, which is the list price. So this is the sticker price on the drug. So this is what the wholesaler pays to the manufacturer. So that's what you see in the news. Another important concept is the net price, which is the list price minus all the discounts the manufacturer gives to pharmacies, wholesalers, hospitals, consumers, etc. So net price tells you what does the pharmaceutical firm actually get. And then remember, who's paying for all of this? We are paying for all of this. So that's what I'll call net expenditure, which is when you sum up what you paid to the manufacturer, the pharmacy, the PBM, the health plan, what is the total amount we're paying for this? And so what does the data from the insulin market tell us? This is what's in the news, which is list prices are rising over time, and everyone's saying, why are they rising over time? Then if you look at the manufacturer, what you actually find is that net prices are falling over time. So even though the list price is going up, the manufacturer is actually making less money per 100 milliliter of insulin. And the third thing you see is that the expenditures are stable. So we as consumers or as society are paying roughly the same amount for insulin. So now, if you are a good mathematician or logician, you can figure out what's happening in the market, which is if the manufacturer is getting less, but we're paying the same, someone's making more, and that's the middleman, right? And that's basically what's shown in the next graph. So you can see the manufacturer share per $100 of spending declined from roughly $70 to $47, $48, and the middleman's share increased from $30 to more than $50. And you can see, for example, PBMs used to make about $5 per $100 of spending, and now they make close to $15 per $100 of spending. So again, you kind of see that these data are consistent with the other paper, that the middlemen seem to be making more money over time. And we have another paper that explains that the rise in kind of rebates explains the rise in list prices. So when rebates go up, list prices go up. So even though manufacturers set list prices, the list prices might be going up because people in the supply chain want to see that go up. So thank you, and I'm happy to take questions at the end.
Thanks, Niraj. That was great. Sue, over to you.
Hi, everyone. The ITIF report that's being discussed today makes the case for the value of pharmaceutical medicines in our personal lives and in society, but it also explains why it's crucial for policymakers and regulators to zoom out from the multi-year fixation on the drug industry and address other players in the healthcare cost ecosystem. I really want to be clear that the Alliance is not advocating for any policies that will allow pharmaceutical companies to go unregulated. We don't endorse any medical products or take positions on whether the FDA should approve products in clinical development. But this is a walk and chew gum moment for the administration, for Congress, and for the advocacy community, because truly effective and long-lasting healthcare cost reform is not going to happen until we grasp and are willing to look at the role of public and private payers, hospitals and health systems, and the wholesalers and the pharmacy benefit managers that are in the middle. Think about how 3 major PBMs serve approximately 80% of the market. As Dr. Sood's research shows, the need for pharmaceutical manufacturers to increase a drug's list price and then increase its PBM rebate to be competitive leads to a big gap in a drug's list price versus its net price. And this gap has major consequences for patients and families because out-of-pocket costs are based off of list prices, not the net prices. Currently, the drug rebate savings flow entirely to the PBMs and partnering insurers, and sometimes to employers. Uninsured patients are then forced to pay the increased list prices, and insured patients are charged higher coinsurance and higher deductibles. So the current dynamic has a substantial impact on a patient's level of care. And there was a 2019 IQVIA Institute report that found that more than 40% of patients abandon prescriptions at the pharmacy counter when their out-of-pocket costs reach between $75 and $125. Older adults that are on fixed incomes are often forced to make decisions between purchasing necessities like rent and groceries or medication. And it's particularly true for older people of color and those who are living in rural areas that have more limited access to providers and pharmacies. And for these reasons, the Alliance supports PBM rebate reform, including policies that would base patient coinsurance and copayments on the net price rather than the list price. And a September 2021 Morning Consult survey that we commissioned showed that 86% of individuals age 60 and older supported that type of reform. Now, many of you know the experience of going to the doctor for yourself or with a loved one and being told that you must first try and fail on a standard treatment before insurance will cover a newer, better one. This is a type of utilization management called step therapy, and it's regularly used by PBMs and insurance companies just to save money. Within a PBM formulary, drugs are divided into tiers or benefit categories according to cost and required level of cost sharing. And there can be up to 7 formulary tiers, with the lowest tier representing generic drugs and the upper tiers containing higher cost specialty drugs used to treat conditions like cancer, rheumatoid arthritis, and MS that are more complex. And the placement of drugs into higher tiers is intended to encourage patients to try the cheaper generic drugs and avoid the use of what an insurance company might consider non-essential. But for older adults who have conditions like macular degeneration, for example, which is the most common type of vision loss, time spent on step therapy can mean additional irreversible damage to their vision. So this creates a double jeopardy scenario where the sickest patients are forced to bear the largest financial burden due to the required cost sharing of the drugs in progressively higher tiers. And it's important to note that the new IRA provisions on direct negotiation don't prevent this type of utilization management from continuing to happen. Reimbursement rates to pharmacies from PBMs have also been steadily declining over time, often to the point that PBMs reimburse pharmacies below their actual cost of acquiring the medication. And this practice unfairly impacts independent community-based pharmacies, both urban and rural, that provide more hands-on services to older adults and people with disabilities. Low reimbursement also impacts independent pharmacies' long-term viability. And these pharmacies are the ones that often have firsthand knowledge of their customers' personal health issues, and they take extra care with them. The lack of competitiveness that has arisen from PBMs underpaying these small independent pharmacies or restricting patients from utilizing them directly impacts the patient by further endangering access to affordable medicines. Now, the impact of biopharmaceutical innovation is only as strong as the access that patients have to it. So I want to touch on 3 additional issues that worry us right now at the Alliance when it comes to access to care. The first issue that we're concerned about is that the Centers for Medicare and Medicaid Services that manages the Medicare and Medicaid programs is that they may use quality adjusted life year or similar cost effectiveness methodologies, such as the equal value of life years gained or the EV-LYG, to implement price setting that is coming for prescription drugs in the Medicare program. The National Council on Disability, which is an independent federal agency that's charged with advising Congress regarding policies, programs, and procedures that affect people with disabilities, has repeatedly illustrated the harms of QALYs and EV-LYGs on access to quality care for people with disabilities and people with chronic illnesses across the lifespan. And they've consistently written letters to Congress and CMS to explicitly ban their use in federal health programs and policies. There was a letter that was organized by the American Association of People with Disabilities that we signed and more than 100 patient advocacy groups signed that state, we strongly urge policymakers to reject potentially catastrophic legislation and policies that reference QALYs and similar metrics, which reinforce health inequities, devalue people with disabilities and chronic conditions, older adults, and communities of color. While the ACA language appears to ban the use of QALYs and similar metrics in Medicare, there's uncertainty whether or not this applies only to comparative effectiveness research or to the entire program. And in fact, private payers that operate Medicare Advantage plans often use QALYs in their coverage and formulary determination processes. And there's not currently an explicit statutory ban on the use of these measures in Medicaid or other federal programs. Second, we're worried about the threats to FDA's congressionally authorized accelerated approval program. Under accelerated approval, a drug obtains earlier approval if it shows an effect on a surrogate endpoint that's reasonably likely to predict a clinical benefit to patients. And the use of this accelerated approval program has been really important for the FDA to allow for earlier approval of drugs that treat serious and life-threatening conditions like HIV/AIDS, cancer, and rare diseases than would occur if they had to go through traditional approval. And Congress recently reiterated the importance and intent of this pathway by strengthening the program in Section 3210 of the Consolidated Appropriations Act of 2023. But there are currently multiple threats to this pathway in both Medicare and Medicaid, and it's all about just cutting costs. There was a published study in AJMP by Emory's Dr. Ken Thorpe and former CBO director Dr. Doug Holtz-Eakin that found that accelerated approval drugs account for less than 1% of overall Medicaid spending per year between 2007 and 2018, but they often represent the only treatment options available for beneficiaries. And they concluded that, quote, limiting coverage for accelerated approval drugs would have a devastating impact on patients benefiting from these treatments while having a de minimis impact on spending. So in short, you're not going to get a lot of juice for the squeeze, except for hurting patients with rare and complex diseases that don't have other options. And plus, if companies see no way to coverage, good luck to all of us when someone we care about gets hit with a condition that either has no treatment or has run out of current treatment options. Last, I want to talk about the value of an FDA-approved treatment called Leqembi that's been in the news lately. And that slowed progression of early Alzheimer's by 5.3 months over an 18-month trial. Leqembi was approved by the FDA under accelerated approval early this year. And even some neurologists who were skeptical of Aduhelm, which was approved about a year and a half ago, say Leqembi could be a game changer. And last week, the Veterans Health Administration announced that it will widely cover Leqembi. But the Alzheimer's community, including the American Academy of Neurology and more than 200 research experts in the space, have had to plead with the Centers for Medicare and Medicaid Services to revise its extreme Medicare coverage restrictions. CMS has applied an extra legal coverage tool that's called Coverage with Evidence Development, or CED, to the drug, as well as to all the other monoclonal antibody therapies for early AD that are in the same class. Coverage with Evidence Development, or CED, has become utilization management for the Medicare Part B program. Again, all about cutting costs. Under a CED, Medicare denies coverage for an FDA-approved item or service except for through a very limited clinical study, either a CED clinical trial or data registry. This is after something has already been approved by the FDA, so it's sort of second-guessing another federal health agency. Once CMS places a treatment in CED, it's very difficult for it to end. An August 22 systematic review of CED and AJMC identified that CMS issued a total of 27 of these NCDs requiring CED between 2005 and 22, and only 4 have been retired by the agency. Several of the current 22 CEDs have been ongoing for more than 15 years. And we just released a new report on CED in February that's called Facade of Evidence: How Medicare Coverage with Evidence Development Rations Care and Exacerbates Inequity. And we found that Medicare beneficiaries in rural communities and in communities of color are more likely to be denied access under CEDs because the conditions of coverage primarily direct care to urban medical centers in wealthy areas. Time matters here. Each day, CMS leaves this misguided policy in place, and it'll be about a year that it's been in place, in about 2 weeks. An estimated 2,000 individuals each day, age 65 or older, may transition from mild dementia due to Alzheimer's to more advanced stage, where they're no longer eligible for the new FDA-approved treatment. From the perspective of people living with Alzheimer's, family caregivers, and society, there's significant intrinsic value to prolonging independence and identity that isn't reflected in medical costs or solely captured in caregiver burden. And that represents real time where cognition, personality, and the ability to care for oneself remain largely intact. And if that value is not reflected in Medicare's value assessment, that's a deficiency in the way that CMS's actuary and their coverage and analysis group is looking at this drug and other drugs because it's planning on expanding this. There are several signs that point to wider use of CED for FDA-approved drugs and devices in the coming years, and Congress needs to decide where they stand on this issue. Individuals with Alzheimer's or any life-threatening illness meet with their healthcare providers, often alongside family caregivers, to discuss the benefits and risks of whether to take a drug or not. It takes a lot of hubris for private payers, PBMs, and Medicare to insert themselves between patients and their doctors in terms of that benefit risk assessment. While managing costs is a laudable goal, It should never be achieved through discriminatory means or in ways that will directly impede innovation in areas where patients need treatment. Our national health care leaders are too smart, creative, and resourceful to fall back on outdated and lazy reasoning that ultimately values the lives of some individuals more than others. Thanks.
All right. Well, thank you, David, Niraj, and Sue, for those excellent presentations. I'm now going to offer ITIF's perspective on the report and the topic broadly of the economics of biopharmaceutical innovation. But for those in the room and watching online, get your questions ready, and we'll take them after this. So in our view, the United States has uniquely, and unlike any other country in the world, come to lead in 4 crucial aspects of the biopharmaceutical economy. First, in innovating new drugs. American headquartered companies have accounted for almost half of the world's new drugs introduced over the past 2 decades. Second, in getting those drugs to patients first. Of the 356 new medicines launched globally since 2011, 310 are available to Americans, but only to 163 to Canadian citizens. In other words, if you're a Canadian, your medicine cabinet is half as full as an American's. In Australia, it's 40%. And achieving these making these achievements while both sustaining a globally competitive industry and over time making drugs broadly affordable by incentivizing competition and creating generic pathways. No other country in the world can square the circle like this. Yet most miss the fact that the United States used to be a global also-ran in biomedical innovation. In the last half of the 1970s, European headquartered drug companies introduced twice as many new-to-the-world drugs as American ones did. Throughout the 1980s, less than 10% of new drugs introduced first in the world were introduced first in the United States. But over the past 4 decades, we have completely flipped that script. And in ITIF's view, that's in large part been the result of a set of conscientious and intentional public policy choices designed to make America the world's leading environment to conduct biomedical R&D and innovation. 5 core policies. First, world-leading levels of public and private investment in biomedical R&D, research and development. Second, the creation of incentives, such as the R&D tax credit, with the US implementing the world's first in 1981, and other measures like orphan drug tax credits and market exclusivity. Third, robust provisions and protections for intellectual property rights. Fourth, very effective technology transfer and commercialization policies, especially here the Bayh-Dole Act, which enables universities, nonprofit research institutions, and small businesses to own, patent, and commercialize innovations developed through federally funded research programs. The Economist called the 1982 Bayh-Dole Act perhaps the single most inspired piece of legislation in America's history, doing more than anything else to reverse America's precipitous slide into industrial irrelevance. It has really led to the blossoming of academic university technology transfer offices across the United States and been directly responsible for at least 200 new drugs over the past 20 years. And fifth, a drug pricing system that recognizes the tremendous risk and expense of innovating new drugs, as well as the need for firms to realize earnings that can then be reinvested into future generations of biopharmaceutical innovation. So in our view, what shines through in this report is that America earns a tremendous return for every dollar it spends on drugs. David Cutler's work documents the impact of medicines on increasing American longevity, let alone enhancing quality of life. But others' work has focused on quality of life improvements and ancillary societal benefits, such as fewer missed work days, decreased use of disability insurance, and increased economic productivity. In fact, Columbia's David Lichtenberg has estimated that from 1997 to 2010, the value of reductions in work loss days and hospital admissions attributable to pharmaceutical innovation was 3 times greater than the cost of new drugs consumed. Far from being seen as a core driver of increased healthcare system cost, drugs were actually a key part of the solution. Moreover, America's biopharmaceutical industry is the world's single most R&D intensive industry, investing 24% of its sales in R&D, a rate 8 to 12 times the national average, and employing fully 1/4 of America's R&D workforce. America was fortunate to be able to draw upon the tremendous bench depth of biomedical scientists, research infrastructure, and database of novel molecular compounds so that we could rapidly respond to the COVID-19 pandemic with effective and novel vaccines and therapeutics. Now, some assert that US drug prices are rising dramatically. Yet drug channels, Adam Fine finds that the growth in both list and net prices for brand name drugs decreased consistently from 2014 to 2021, and that net prices for brand name drugs actually fell each year between 2018 and 2022. Over the past 2 years, prescription drug prices have risen at just 1/3 the level of the overall consumer price index. And the Bureau of Labor Statistics, BLS, finds that over the past 15 years, consumer expenditures on healthcare almost doubled in the United States, but their expenditures on drugs actually decreased by over 8%. Yet, against this backdrop, we find, as Niraj pointed out, that the share of each dollar spent on drugs in the United States going to the companies that actually innovate and manufacture them has been declining. Niraj presented data from 2015 suggesting that the innovators keep about 60%, but we heard as well at the symposium from Mr. Andrew Brownlee of the Berkeley Research Group, and his research finds that from the years 2013 to 2020, the share going to manufacturers declined over 17 percentage points from 66.8 to 49.5%. So Brownlee's research updated to 2020 finds the innovators get less than half of every dollar spent on drugs. Meanwhile, Niraj's research suggests that these middlemen are significantly more profitable than at least the pharmaceutical manufacturers, if not the biotech ones, but yet they invest at best a fraction of the revenues in R&D and innovation. I can guarantee you that the PBMs and the wholesalers are not spending a quarter of their income on R&D, nor employing a quarter of America's scientists. And this is concerning that the middlemen are capturing a larger share of the revenues, because this results in fewer resources that can be devoted to R&D, which subsequently means fewer biopharmaceutical innovations for Americans in the future. Indeed, as the OECD finds, there is, quote, a high degree of correlation between pharmaceutical sales revenues and R&D expenditures. Virtually all academic assessments find that there is a direct correlation between companies' investments in R&D in 1 year and their revenues from the previous year. So putting this all together, in ITIF's view, it's important that policymakers understand the full panoply of factors affecting drug prices in the United States, and that instead of broadly applying drug price controls, we focus on promoting affordability, especially through mitigating out-of-pocket costs for individuals, especially seniors. Also, it's important that American policymakers focus on cost, not just on prices. And what I mean here is that there's much we can do. Then policymakers can consider how to help increase drug R&D efficiency, including by boosting NIH funding and increasing investments in public-private partnerships like Manufacturing USA institutes that are working to develop new technologies that can decrease the cost of drug discovery, development, and manufacturing. A recent report from the Government Accountability Office estimated that the application of AI and machine learning to drug development can reduce the cost of each drug innovated going forward by $300 to $400 million a year. We should be using these tool sets so that we can drive down the cost of drug development discovery while maintaining the profitability companies need to reinvest in future generations of innovation. So in conclusion, this broader debate about price controls, in our view, is really not one about whether society wants lower prices in exchange for lower drug company profits. It's about whether society wants lower drug prices today in exchange for less and slower drug innovation in the future. So while we do need to address issues regarding drug pricing, what's needed is reform, not wholesale transformation. And we have to recognize that widespread drug controls would almost certainly reduce our biopharmaceutical competitiveness, especially as China tries to turbocharge the sector while slowing the rate of new drug development for Americans. So thank you. And I want to open the floor now to questions from the audience for our participants. Please, if you would just state your name, the organization you're with.
Brian Darmody with the Association of University Research Parks BioHealth Caucus. Stephen, you mentioned the Bayh-Dole Act. I think it was on Wednesday or maybe Thursday, NIH rejected a margin rights for a particular drug. But on the other hand, the government announced a whole of government approach to looking at margin rights with NIST and NIH and others. So I was wondering if the panelists had any comments on margin rights. And just a quick question on David. Your data showed a decline in life expectancy in the early 1990s. I was just curious, it looked like a dip and then it went up. Was there anything specific in the early 1990s that you all identified?
So let me first, for the audience, clarify what margin rights mean that Brian's referring to. So as noted, the Bayh-Dole Act is legislation that essentially gives universities the right to license the intellectual property that derives from federal funding. Now, when the act was implemented, there were 4 conditions specified in which the government could, quote, march in and essentially commandeer the IP, or at least force the university, the owner IP, to license it to others. So that's the context of marching rights. I will defer for the moment to my panelists if they have a perspective on the march-in rights question, because what is at issue is that a set of proponents have contended that the government should be able to use march-in rights if the price of the resulting innovation is too high, if it's not reasonably priced. And this ultimately turns upon the actual legislative language about whether price is a relevant consideration for the government to be able to use in the case of march-in. But go ahead.
Is this on? Okay. So I think my view is that the returns to R&D, if you look at it, it's not like every drug makes 5%. There are some drugs which make a lot of money, and there are a lot of drugs which make no money or zero money. So now if you just selectively pick the winners and say, hey, your patents are not valid here, that's going to tremendously affect the returns on R&D, right? So if you're a university and you're spending money on a tech transfer office, you might have 100 startups, but only one of them is profitable. And that if that one startup, the government comes in and says, we have march-in rights, that tremendously changes the incentives for the university to invest in tech transfer. So I don't know the details of this case, but broadly speaking, that's the way I think about this.
Let me just give a couple of comments. On the first point, I would have to look at it more, but I think what that was the sort of tail end of the crack epidemic and increased homicides resulting from that. Just on the broader issue of the pricing and all of that, one thing that strikes me in looking at the data that I've seen and other studies is that in some sense you can't treat the industry as a whole. So there's some products which are very reasonably priced and super valuable, and there are other products that are extremely expensive and not so valuable. And it's very difficult to have one policy that that tries to do everything. And so, so for things, so people sort of don't mind so much, at least the scholar doesn't mind so much if a product is priced very high and it has enormous benefits. But if the product is priced really high and it doesn't have very many benefits, but then it still gets used a lot, and then it looks like a big waste because whatever reason, that's really sort of like a huge loss of resources. And so I think it's, in my own mind, I try and keep a somewhat nuanced view about it for that reason. And I also just, one other thing, and it's sort of, Sue mentioned it a little bit, but it's worth pulling out, which is sometimes a drug may be small overall, but for the people taking it, the out-of-pocket cost can just be enormous. And that presents a real problem. And that's in fact some of what employers and other insurers do, is they say, well, I'm going to keep the premiums low by jacking up the price to people who are less healthy. And that's just a terrible thing to see, because you often have medications that people desperately need that they can't afford. And the reason is because other folks that look at me, and everyone with insurance is just not willing to pay a few dollars more a month so that other people can get it at a low price.
The only thing I would add to what's already been said is I think that the idea behind it is really to perpetuate sort of this false narrative that NIH is the major investor in drug development, when there's, really kind of a imbalance where I think it's for every dollar from NIH, it's 3 from industry. So it's, perpetuating this idea that everything comes from the NIH funding. And universities get enormous amounts of revenue from purchase, to Dr. Sood's point. So it's not as if there isn't, a transfer of funding. So it wasn't designed for the purposes of controlling drug prices.
By the way, on that point, I don't know if y'all had the time to read the Washington Post this morning, but Amy Maxman has an article addressing the pricing of the COVID-19 vaccine of Moderna. But she quotes the stat that, in fact, of all the 210 drugs approved by the Food and Drug Administration between 2010 and 2016 were based on research supported by the National Institutes of Health. I think gross misreading of what that report actually found. What it found was that of these 210 drugs, there was some small part that you could attribute. Maybe there was a biomarker, a pathway indicator for a drug that came out of research, or some scientific cause of method. So yes, NIH research did play a part, but to suggest that these drugs were fundamentally based or created on research supported by the NIH is just, it might be fallacious. Brian, to also answer your question from the ITF perspective on the margin rights and your point about now there being a broader whole of government investigation later this year. I hope that what that reveals is that the understanding of the margin right provisions, particularly as they reply to reasonableness, reply to the practical application of the invention. And that's the responsibility of the licensor, not the licensee. And that we can hopefully move beyond this debate over price controls as pertain to margin rights, because in my view, it's sending us back from the more important task of actually innovating new drugs.
Yeah, Ulrich Newman from J&J. I have a question, I think that sort of connects both of your work, David and Niraj, and that is, we seem to have, and David, you were calling for proportionality. Let's look at individual drugs and see what value they gather, and that should be what we should be doing. It seems often when we talk about drug pricing, we talk about the 50% that we can more easily maybe measure, which is not that percentage, Niraj, that you're saying, goes to the supply chain. And we seem to have some good methodologies, and we can debate them. On the one part, we seem to be struggling a little bit about how to assess the value of the rest of the 50% that is a cost. And so I wonder from your research, how could we find better ways to ask the value for money question for that other half, knowing that that is really the path that goes up, and that's probably not the R&D focused path. Not saying that there's no value there, but it seems that for an entity that doesn't really ship drugs, that doesn't really have a touch drugs, that if arbitrage is the business model and it seems to always go up, then how do we assess that? What methods, economic solid methods do we have for that?
So I would love for David to write a paper on how PBMs have increased life expectancy or changed life expectancy. But I think one of the roles of PBMs or what their role is supposed to be is to reduce the cost for the health plan, and then in return for the health plan to reduce the premiums for consumers, right? So in the end, what you want to see is that the total cost that we pay is going down. And that's just very difficult to estimate because the system is highly opaque, right? And now I think there is new laws where they're trying to kind of go inside the black box and try to figure out what the actual practices of PBMs are. So the FTC is doing a major investigation. So I think those investigations will kind of shed light on this issue, that what is the value we are getting from the supply chain. But I think right now it's very difficult to do that because the system is just so opaque. It's like all the numbers I presented, there's a lot of measurement error there because, we were just dealing with what we could find in public information, and it's not perfect. So we're kind of painting this view from a 30,000 feet level. But I think, and ideally, I'd love to do this for every drug because, as David said, things might be different for some drugs versus other drugs. So ideally, you'd want to kind of do that in a more detailed, granular level. And I'm hoping that with these new laws being passed and more investigations, we will see, more of that.
I'll just add two quick comments. One is that most of the middlemen seem to make more money when list prices are high. And so there's an incredible incentive in the system to keep list prices high, which is really just absurd because there are people who ultimately pay list prices and they don't have a ton of money. And so I think that's just a really terrible situation to put people in. And then the second point about it is that this market is sort of becoming very concentrated. And in part, that's because they're fixed costs, like, distributing things involves a fixed cost and so on. But one of the other things about concentrated markets is that they often permit very high markups. and trying to think about ways to either prevent mergers or to say, look, let's reduce those fixed costs so that we can have more competition. And then competition often brings the benefits to consumers. But if I've only got a small number of things in the middle, then of course I'm going to look for very high prices and high profits there. And that consolidation has been very, very sustained over time, both across companies and also just, the big players getting bigger because of whatever it is that they can bring to the table.
I would just add to that it's not just kind of the horizontal consolidation. So I think Sue mentioned or Steve mentioned that the 3 PBMs control 85% of the markets. But the 3 PBMs also own their own health plans, also own their own pharmacies. So now if I want to compete in this market, I have to be a PBM, pharmacy, health plan, specialty pharmacy, everything else combined. And so now to enter this market and install more competition is super difficult because I have to be this large vertically integrated player.
By the way, those 3 PBMs you mentioned are now 12 of America's 15 largest companies with an 85% concentration rate. And while some have said that the pharma industry is concentrated, the reality is that between 2002 and 2017, the C8, which is the concentration rate of the 8 largest firms, actually increased from 54 to 58%. So not nearly as concentrated. We had a question online, which was, why do you think insulin manufacturers have been increasing list prices? David, I think maybe your remarks kind of answered that question, but Niraj, would you want to add anything else?
So I think the answer is that they've been increasing list prices because they need to pay higher rebates to the supply chain. But more recently, all the 3 big manufacturers announced that their list prices are going to go down by 75% or 70%. And that's a big change in this market. So basically, now all these 3 manufacturers seem to be saying that we don't want to play the rebate game. We've taken enough flack for rising list prices. And so I think it will be very interesting if this trend goes to other drugs to see if this happens for other drugs. But I think what's happening in insulin right now is a pretty big change. And I think good news for consumers.
So a question from the interwebs for you. Some argue payers preserve patient access to treatments by preserving budgets and spending. Any thoughts on a better approach beyond price controls?
Well, I mean, I think that the discussion of premiums has always been sort of like a sacrosanct area. You can't touch, the idea of increasing premiums. And it's interesting because if you look at the reports from the CBO that came out in December on the biggest deficit reducers in healthcare, the 2 things that they mention are, controlling the out-of-control costs in Medicare Advantage, the overpayments, and then also raising premiums. And those can be done by income level and Part B in particular. So I think that, this whole idea that you have to compete by controlling those premiums, I mean, we're around older adults all the time. And during open enrollment, I love the whole, I don't pay anything and I just pay this amount. And, there's kind of like a compare and contrast. And there's certainly a lot of seniors that are on fixed income. It's not in any way to minimize the importance of what folks have to pay out of pocket each month, but it goes down tremendously, from what we're used to paying and when we're still employed. And I just think that's an area that we need to take a look at. And the fact that the aging population has grown so substantially, this whole sort of slash and burn approach, everything is about cutting everything instead of recognizing that we've had this tremendous growth in this aspect of our population. We need to rise to the occasion, not kind of cut everybody off.
All right, I'm going to cue final questions here in a second, but David, there's one for you, a technical question, I think online, asking, are medical devices included in the category of pharmaceuticals or are they in the other category?
They're in the other health part. They're not, medical devices are not in the pharmaceuticals. Thank you for the question.
Okay. All right, any final questions from our audience? And I think what I'm going to do to wrap up is ask if each of our panelists will just give kind of a 30-second kind of key takeaway that you'd want the audience or policymakers listening today to take away from the conversation.
The key thing that the way that I think about pharmaceuticals and all medical care is in terms of value and how do we improve the value that we're getting. And there are two parts to that. There's the cost part and there's the return part. And so some of what we've shown here is that the returns have been very high. And of course, that's in the backdrop of costs being very high. And to me, the absolute fundamental priority is how do we increase the value that we get for the system? And that means taking things that are overpriced and making them be cheaper, but also taking things that are extremely effective and making them be more widely available. And so I don't think, so this is sometimes posed as a sort of put your foot on the brake question, which is not right. And it's sometimes posed as, just push the gas pedal as hard as you can, which is also not right. What you want to do is have a nice smooth path to get where you want to go. And that should guide all of our policy here, I think.
Great, thank you, Naresh.
What I'll say is that we should look at the whole problem. So the entire supply chain and not just 50% of the problem, which is just the drug manufacturers. And I think the other thing I would say is, working with the market system and installing competition and transparency is, I think, the best way forward to address this problem.
And I would say that, I think Congress needs to take a closer look at Medicare coverage issues and the fact that, it used to be the FDA approved a device or a drug or any type of medical product that, consumers could have access to newer things and we would be able to sort of move forward with innovation. And that's not the case anymore. So I think that Congress needs to sort of take a close look and see what they can do at their level to make sure that there is some presumption of coverage that beneficiaries can depend on.
Great. And I think I would add, and from our research, we've looked at the evolution of life sciences industries in Japan and in Europe, and it's very apparent that stringent drug price controls in those countries have totally decimated their industries. From 1995 to 2018, Japan's share of global biopharmaceutical value add declined by 70%. And you can almost see corresponding one-to-one price declines that they paid for drugs over that time. As I mentioned earlier, between the mid-1970s and today, we have completely flipped the script with Europe on the share of new drugs innovated here versus there. So there's much that is working effectively in our system in the United States. So I would encourage policymakers to tread lightly and cautiously and be mindful that for kind of investors in this industry making decisions at the margin, even playing with the possibilities of March-in rights or buy-dole revisions, et cetera, and really moves capital out of this very risky and expensive enterprise of drug development. So we got to get it right. One final question came in online. This is, how do you explain innovation economics to a 5-year-old? This is clearly based on Rob and I's book, Innovation Economics, The Race for Global Advantage, and clearly from my sister. So thank you for watching online, Julie. I will work on it. And hopefully we can come out with a primer for the youngsters. With that, I want to thank you all very much for joining us today. David, Niraj, Sue, especially thank you. This video will be this afternoon available on YouTube for further watching. And thank you for your time.
Thank you.